So welcome to this session entitled Optimizing Oocyte Yield. We have the honor to have two very distinguished speakers who accepted this invitation. On behalf of myself and my co-chair, Dr. Borini, we will invite the first speaker. The first speaker is Bart Fauser. I think all of you know him. I'm not going to read his CV because it's another lecture, but I will tell you that he's honorary professor at the University of Utrecht. He's been the editor of Human Reproduction Update and is currently the editor of RBM. He has published more than 500 papers with a Hirsch index of 104. His lecture is entitled, Can Ovarian Response Be Predicted? And why should we want to know? Bart.
Thank you very much, Mr. Chairman. Let me start with expressing my gratitude towards the audience. Number one, look at the room here, all packed, and look at all the people still waiting. It may be good for the ego of some. We just discussed it with the next speaker. Also, I would like to congratulate Stratus with the thought-provoking lecture you gave earlier this morning. It's good for modesty for all of us. And I have to say that my emphasis is slightly different. I am a believer in individualized medicine and individualized ovarian stimulation. And I think it's up to you to see how or whether I'm biased or not. So the organizers gave me the title, Can Ovarian Response Be Predicted? And I added the sub-sentence, and why would you want to know? Why would you care? So my disclosure of interest, next to being chief editor of various journals and being a board member of various national and international organizations, I've also been acting for quite some time as a consultant for pharmaceutical companies. And in the context of this lecture, I would like to mention the company Ferring, because I will mention some of the studies where I've been involved in later on. Something is not... I don't want to dwell on my disclosures too much. Okay, just to keep you going and make you think, organize your own mind. The inconvenient truths of ovarian stimulation for infertility treatment. And even listen to lectures earlier today at this ESHRE meeting. There has been a lot on ovarian stimulation. So ovarian stimulation represents the most common intervention in infertility care. I think we can all easily agree on that. Most current ovarian stimulation strategies are extremely complex, expensive, and not without danger. And I will dwell on these issues during my presentation later on. The added value, that may be the most controversial for many of you, of ovarian stimulation to treatment success remains a matter of debate. That's why it's so widely discussed and published all over the place. Ovarian stimulation is often uncontrolled. Whether we like it or not, that is the truth. And I heard this morning again lectures about controlled ovarian stimulation. I would say, wake up. Ovarian stimulation is not controlled. That's why we talk about it so much. If it would be controlled. So this is, I would say, wishful thinking. We would wanted it to be controlled. But let's face reality, it's not. We all practice individualized stimulation, mostly based on personal experience, rather than sound scientific evidence. This has been outlined by a colleague earlier today, and I fully agree. Ovarian response predictors are the key determinant to personalize ovarian stimulation in a robust manner. And again, I hope I can convince you that this is indeed the case, but there's still a long way to go, and science-based individualized stimulation is at its infancy. So we just got started. It doesn't mean the proof that it works isn't there. That does not mean it doesn't work, but just we didn't try hard enough to do the right studies, in my opinion. So I will briefly go over various concepts, and I try to avoid to zoom too much into details because we all got lost in details. So I try to emphasize the bigger picture. So I would like to spend a few words on ovarian stimulation, which I still feel that many people confuse these different ways of stimulation. Individualized ovulation induction, so the treatment of anovulation. You may not know, but the history of ovarian stimulation for IVF, now so heavily discussed, has a relatively short history compared to the history of ovulation induction. You know, that has a 50-year-old, and there were mostly medical endocrinologists involved in ovulation induction, and therefore I would say the scientific basis of ovulation induction is much stronger than the scientific basis of ovarian stimulation for IVF. So ovarian stimulation, again, we should make a distinction between ovulation induction, which is the treatment of anovulation. It's almost disappearing in the ART-focused gynecology area, but again, there should be a lot of room for just ovarian stimulation, ovulation induction. And this as opposed to ovarian stimulation, either in the context of empirical treatment, or in the context of IVF. And there usually you start, not always, but usually you start with women that have normal ovulatory cycles. And there, of course, what you want to achieve is multiple follicle development. And therefore, if you do this empirically, with or without IUI combination, you should not be surprised that your multiple pregnancy rate will go up. You know, that's all what you're doing. You try to have multiple follicles ovulate. So what is the aim of ovarian stimulation, just very much in general? And I think it is so self-serving. You like to maximize benefits, and then, of course, we have to define more clearly what these benefits are. Minimize complication, risk, side effects, burden, and cost. If you think about this, I think if I would ask all of you individually, I think nobody would disagree with this. It's a no-brainer, isn't it? But when you look at the studies, these hundreds, if not thousands of studies that are performed in ovarian stimulation, very, very few address more than one of these issues. Usually, it's just about one endpoint. Collie has discussed the nomogram. I think this is, again, from ovulation induction, much earlier than the one you showed. So we have worked on this in the 90s. Can you almost feel ashamed to discuss studies that were taking place 25 years ago. But this is just what we did in the 90s. Prospective cohort follow-up studies, again, in ovulation induction, not ART, ovulation induction, where we start with thinking, we know that clomiphene citrate as first-line treatment is not so very effective. Wouldn't it be great if we know beforehand the ones that will respond favorably and the ones that will not, rather than just wait and see and waste a year for the majority of women? We know that the cumulative pregnancy rate with clomiphene citrate does not reach 50%. And we found some predictors and developed a nomogram. And again, I will not go in detail. If you're interested, you see a whole series of papers published by our group at the time. So first, you can predict ovulation, and then in ovulatory women, you can predict the live birth rate. And for sure, this needs to be repeated, tested, validated. It never happened, unfortunately. So I think this is a valid scientific study, but it needs confirmation. So I will not recommend it, but it's just to make you think, this is a different way than doing all big sample size RCTs. It's a different strategy. This is a paper published 10 years later by Rick LeGros and his group from the US, the Reproductive Medicine Network. It is a post hoc analysis, but I like it, and also I like it because it's simplicity. These are these charts with colors, and of course, red means bad news and green is good news, so a good prognosis and a poor prognosis. This is very common in cardiovascular research. I don't know whether you're aware of that they have the 10-year risk for cardiovascular disease, based on cholesterol and metabolic syndrome and lipids and blah, blah, blah. So this is the same applied in our specialty. again in ovulation induction. Published again 10 years later, JCNM. I've been invited to write an editorial, so which we did to put it in perspective. So I think a really important first step that did not generate enough attention and follow-up studies, unfortunately. Then very recently, only I think this month or a month ago, the same reproductive medicine network published a much larger study where they combined ovulation induction and empirical ovarian stimulation. And they came with the following predictors for outcome: female age, partner's age, interestingly, BMI, treatment type, medication. And AMH was only a predictor for multiple pregnancies and not for pregnancy itself. So I don't know why. They all, again, asked us to write a commentary around this. The key points were, this is post hoc analysis. The studies that we have been doing were really prospectively designed to look at predictors. These were not. These were comparing different medications. I'm not sure how valid it is to compare to group different patient groups together or to group different interventions together. And here as well, no external validation, at least not yet. So a great start, but we need to do a lot more. And again, this gives rise to a different way of thinking how we could move forward. So, to conclude the ovulation induction section of my presentation, I know it's often debated, what is the future of ovulation induction? Does ovulation have a future? And I know that many patients that would qualify for ovulation induction around the world, they go to ART right away. So almost more and more ovulation induction is forgotten. And is that really in the benefit of patients? I wonder, I question that. Maybe, rather than thinking black and white, we continue as we are doing it or we don't do it at all, maybe there's something in between and say, let's focus on the poor prognosis patients with a much lower chance of success than 50%. And in those group, go for different strategies. And check the literature, there's not been a single study published in this area with these starting points. So then about the bigger picture of ovarian stimulation, now we move to IVF. And I know that this is not something that you would like to hear, but my perspective of ovarian stimulation is that it is much, much more complicated than what we usually hear, because it relates to burden of treatment and the need for frequent monitoring. And burden of treatment is very clearly related to dropouts. If you have a highly successful one-cycle program, but these women that don't get pregnant say, never ever again in my life, it was a horrible experience, then you don't have cumulative chances for added benefit of ART. You will find very, very few studies to focus on this. And this is not new that I mentioned this, but for whatever reason, it is usually ignored. Now, of course, we know about OHSS risk. Now there's more and more indirect evidence that ovarian stimulation is related to luteal phase, to corpus luteum function, to endometrial receptivity, but also placentation, pregnancy complications. Wow, so we are getting into a lot of trouble. We may solve some problems, but we get 3 new problems instead. Is that really what we want? Let alone about cost. In many countries, like mine, medication costs are very high. And of course, in areas in the world where it's not reimbursed and where it's very expensive, that means that those women have no IVF exposure at all. So the cost is directly related to access to care. So if we would simplify and reduce cost, of course you would have a tremendous increase access to care. And all the things that I usually hear about ovarian stimulation and lectures and it's only making it more complicated. It's rarely making it less complicated. So I am for uncomplication. So I mentioned we made ovarian stimulation very, very complex. We've worked on this for the WHO, summarizing. It's not just the stimulation, it's the pre-stimulation, it is the co-stimulation, it is the post-stimulation. Wow, how complicated did we make it? And There's the guidelines, the ASHRAE guidelines. I read them carefully for this presentation. The word personalized ovarian stimulation, I couldn't find at all in the report. They come with. I see some people laughing, so I'd like to hear your comments later on. Of course, I'm doing this to trigger the discussion. Even they said, they have one table, which I show, one figure, that they say we identify some areas where we think there is progress and not enough studies. So we would like to encourage new studies in this area. Now, there are 6 of them, nothing about individualized stimulation. I really wonder why. So again, ovarian stimulation, certainly in the context of ART, is not controlled. Wake up. And also the term, I've seen it this morning again, controlled ovarian stimulation, COS, no longer exists. Look at the glossary, 2017. Finally, for me, after fighting for 10 years, they removed the word controlled. I think, come on, let's be real. It is ovarian stimulation. And of course, we all have our favorite regimens. Sometimes we are surprised. Again, heard the discussion this morning about the OHSS frequency. So by the hyper response, which predominantly means danger, or a hypo response, which usually means poor outcomes. And of course, here again, wouldn't it be wonderful if you would know in advance who is going to be a hyper responder? How simple is that, isn't it? We can easily, argue that maybe you should change your strategy if you know that somebody is going to be a high responder. For a hypo responder, it's slightly more difficult because that's often an intrinsic problem of the ovary. So we know these studies. This is actually performed by Frank Broekmans from my group. I presume he's somewhere around here. This is about AMH being a predictor, both of. So yes, hyper response and yes, hypo response can be predicted. And this is the most IPD meta-analysis. It's the most strong evidence available. Overall, you see more than 10,000 patients are analyzed and IPD analyzed. So yes, you can predict clearly. Problem is that now more and more AMH is considered to be the key factor, but I have to emphasize that AMH assays are even today not without problems. This is a slide I modified from Scott Nelson, an expert in AMH, and there are still issues with the AMH assay. So even today, it's relatively good. Think about how much better it could become if we solve the assay problems. Storage problems, different antibodies being used, acknowledge that there are differences in absolute concentrations. So there are still a lot of problems that we face with AMH assays. And there's a lot of room for improvement if we get our act together. So then about patient-tailored ovarian stimulation. I've been writing a mini review on this in Fertilsteril, 5 years ago. At that time, 5 RCTs were known, particularly focusing on this area. The first one is actually von Nibo-Andersen group in Copenhagen, quite some time ago, as you can see. They found, and this is prospective cohort follow-up study, so which patient features upon initial screening are linked to outcome. And I will not go into detail, but you will see here the different factors. Oliven, that's a retrospective analysis of an existing database. Nibo-Andersen, that's a study with folitropin delta, I will show you. Allegra is from the Italians, a small study using several factors. And von Tilburg, that's the Broekmans study. I was actually thinking this morning, Frank, it's called the Optimist trial. And you were really optimist by starting this study, because the aim at the time was increased pregnancy rates. And Frank, you remember, I said from the very beginning, how valid is that endpoint? And you didn't reach it, and therefore you say, it may not work so very well. We came with different conclusions around folitropin delta, although, as you also admitted, the data are not so very different. So this is a new recombinant FSH produced by a human cell line. The existing is not by a human cell. So glycosylation structure is slightly different, and therefore the characteristics of the compounds are different in terms of half-life. So they had to do the studies from scratch. This is a dose finding, makes a lot of sense. It's based on weight, not IUs. Increasing the dose, you see the black line on average, increasing oocyte numbers. Dose-response relationship, but already before, at the design of the study, people realized that AMH could be a predictor, and therefore they stratified into high and low AMH. And you can see that in the next slide. The blue line is the high AMH group, and the red line, the low AMH group. And what I would like to emphasize here, and again, this is about individualized dosing, that if you want to, for instance, get 9 oocytes, in the high AMH group, you need about half the dose compared to the low AMH group. And it makes a lot of sense, isn't it? If you are a presumed high responder, and if you give less, you get the same outcome. How simple is that, isn't it? So they, based on data, not on assumptions, based on data, they created an algorithm, and the most profound predictors were body weight and AMH. I will not go into details. And I like this, the study, the design of the study. I've been involved in the data analysis and the publication, not as a participating center. And what we try to achieve, and it relates to the title of the symposium of this session, had a number of oocytes. We, at that time, arbitrarily, we decided, you know, what we consider optimal is retrieving between 8 to 14 oocytes. And the primary endpoint was the proportion of patients that were within that range. Again, I like the idea. It's a surrogate outcome, but I like the idea. With the idea, particularly, we have fewer high responder patients with associated risk, and hopefully fewer low responder. And this is what it shows. Again, I will not go into detail, but it shows that it was right. So you can potentially make the treatment safer by having less high responders using the individualized dosing regimen. And I think what is unique now with focus on validation, exactly the same algorithm has been tested, and in the meanwhile it's being published in different parts of the world. So if you think about ethnicity, you know, maybe the algorithm only works in the patient population studies. The 2 additional studies came almost identical results. The second study in Japan and the third study in the Pan-Asian, big sample size, altogether big numbers. So it shows that the algorithm, this is always antagonist co-treatment, by the way, is very, very robust and consistent. So, and based on this, of course, you increase the number so you can look at difference with more power. So based on these 3 RCTs, almost 3,000 patients, you can say there is increased safety. No question about it. There is increased efficiency. You use less drugs, and the clinical outcomes is at least as good, if not better. That's still undecided. So towards concluding my presentation, if we think about optimizing ovarian IVF and ovarian stimulation, but I think for all interventions, the focus should be effectiveness, and then we have to define that. It's not so easy. Safety, both for mother and child, and cost effectiveness, which is often forgotten. So then the first question we should ask ourselves, what are we aiming for? If there's one consensus I would like to recommend to think about and work on, what are we aiming for with ovarian stimulation? We don't really know. We all have our own ideas, and there are often conflicting ideas, conflicting strong ideas about the numbers. What is optimal? What is optimal? What is the lower threshold and the higher threshold? We don't really know. And indeed, if we think about predictors, we have to think about biomarkers, but also about the broader context, the demographics, ethnicity, and maybe also towards personalized medicine circumstances. Of course, if you're a woman in need of IVF and you live in Manhattan or you live in sub-Saharan Africa, of course, what you need is something completely different, based on context. So we have to take all that into consideration. And then at the end, let me be quiet for just 2 or 3 minutes for you. This is the message I would like to bring to you, and I can only hope that they're useful to get you thinking about this topic. Thank you very much.
Thank you very much, Bart. We still have time for a few questions from the audience. Yes, Adam.
Thank you very much, Bart. Adam Balin from the UK. You present some, obviously some big studies based upon choosing protocols based upon patients' current characteristics. But coming to your last slide, and of course I appreciate time didn't allow you to go into this in any detail, do you think as responsible clinicians we should be taking a step back and rather than be driven by the commercial imperatives of getting people into treatment quickly, encourage lifestyle modification, vitamin D levels you mentioned, obesity, all of these things which I won't list, but I think we rush in, pressurized both by patients and commercial interests, and we might serve our patients and their unborn children better if we just take a step back, and I think we're losing sight of this a bit.
Adam, I, of course, 100% agree with what you are saying. Body weight, food intake, smoking, alcohol, certainly also age, of course, male and female. So yes, I think it's a different topic, but yes, very, very important.
Please state your name and country of origin.
Okay. Isam Othman from Egypt. Thank you, Professor Fauser, for an excellent presentation. We all enjoyed it. So my question is, speaking about, or as an advocate of the personalized ovarian stimulation, then we come to the point that some papers or Cochrane reviews did not, I mean, if we individualize the management or the ovarian stimulation, then we face the Cochrane review saying that the fixed dose did not really differ from the dose based on AMH, for example, for having better live birth. So how you kind of match those statements, individualized treatment, and then some papers saying that the individualism did not really make a difference. And then how could we individualize at the time when you mentioned that most of those algorithms have not really been validated? So can you recommend one which was validated?
Yeah, now I think, because if I understand you correctly, it's about what do you compare your algorithm with, and usually there's variation, and of course this was 150 IU, the Recovel trials, and the reason is that that was most commonly practiced. It still is, but yes, how would it be if you would have chosen a different? Of course, we do not know, but that the stimulation is different, that is shown by the response. The ovarian response is significantly different when you compare those two groups. So in that respect, do we need a control? Or should we further focus on fine-tuning the algorithm with, for instance, genomic data, soon with big data? You know, if you do use any given algorithm, and if you monitor how your own patients behave, you can design your own algorithm. So this is just a first attempt, but for sure we are not there yet. And it can be fine-tuned.
Please.
Murat Sönmezer, Türkiye. I would like to learn about your opinion in patients about individualized ovarian stimulation in patients undergoing pre-implantation genetic diagnosis and aneurysm. Do you still offer individualized ovarian stimulation or use higher doses?
Yeah, that's a very good question. It's a different topic, of course. There is, I think the bottom line is, would you like to aim for more embryos if you do PGD? And I don't have any strong opinion yet because there's not really evidence. I know from people around me that most have the view that it's better to have more embryos, and therefore it may be less applicable, because this algorithm, the one I showed, is in a way a fairly mild stimulation protocol. But again, this is more hunches and feelings than data. We don't really know.
Okay. Thank you.
We have two questions from the virtual audience. The first one is talking about personalized medicine. is the preferred optimal number of oocytes not also dependent on female age, AMH, and embryo transfer strategy?
Now, female age is to some extent part of the predictors, and AMH in a way is a biomarker for female age. So yes, female age per se has been tested in the algorithm, and therefore it did not make better prediction models than AMH itself. And of course, knowing genetic abnormalities in older age women, you would like to have more embryos. But that's a theory, that's a fantasy. You can't get more embryos. So we just have to realize that and face that.
And the last question from the virtual audience about artificial intelligence. We lack range of dosage. Artificial intelligence, AI, as I understand, we lack range of dosage for similar patients. Should we constrain our models with evidence-based knowledge, like not allowing negative effects? Anyway, it's about
artificial intelligence in general. I think we all like the word, it sounds good, and we all like big data. The idea is that if you do your own protocol, if you monitor it carefully with artificial intelligence and big data combination, you can learn and you can improve your insight and improve your algorithm if you wish. So I believe that this is going to be helpful in the future. But if we are honest and say, what do we have today to prove a benefit? The answer is we have nothing today. It's a theory and no proof.
But thank you for your excellent contribution to this session. And I give the microphone to Andrea.
Good morning. Now it's my pleasure to introduce Professor Ying Cheong. She is a professor of reproductive medicine and associate dean at the University of Southampton in UK. And she's the director of the Center of Reproductive Medicine in Southampton. She has a tough topic right now because the topic is how to how to optimize gonadotrophin dose in ART. That is, at the moment, it's not so easy. Huh?
Thank you, Chairman. And indeed, I have a tough job today, but I shall try my best. These are my disclosures. I do not think they affect the talk. Now, what are we going to cover today to get to our answer? First, some principles, very simple. You would have heard again and again, in this conference, the principles of ovarian stimulation, not controlled, but the optimal dose of gonadotrophin and where the evidence is, how strong it is. And then, of course, some reflection and some critical appraisal. And, of course, future strategies. And I totally agree with my previous speaker that actually when we consider ovarian stimulation in IVF, we have to remember the objectives, which is basically a happy, healthy baby and minimal risk and complications. And there we mean cancellation of cycles, multiple pregnancy, hyperstimulation syndrome. But I like to add, and I totally concur as well with my previous speaker, that we got to remember that to this day and age, ovarian stimulation is still a very high burden for our patients. And so it is our duty, whilst we, is busy looking at the signs and the dose and the oocyte numbers, we got to remember that a human being is going through the journey and that we got to look after our patient. Now, follicular genesis is not yet totally understood. So the process is actually very complex. Of course, we started off knowing about the FSH window, where you have follicular ovulation, where you have a window that closes with the negative feedback of the estrogen. And then, of course, in conventional ovarian stimulation, we increase the FSH dose, extend the FSH window, and we get multi-follicular development. But of course, more recently, we also know that there are multiple waves within the menstrual cycle, and therefore facilitating various different permutations of ovarian stimulation process. So complex process, we don't quite totally understand it yet, and new concepts and new understandings is still emerging. But we are not short of choice. When we are talking about ovarian stimulation, it's like a child in a big ice cream shop. There's so many nice different types of ice cream to choose. Drugs and co-treatment, single, combination, best time to start, stop, fixed dose, flexible dose, and add anything else you can think of, right? So it is options galore. Where do we start? For patients going through IVF, what dose should we use? What dose? What's the answer? Just enough, of course. But how do we know what is just enough? And that's a very arduous journey that I went through myself to try to write the talk and to share with you today. We start with a journey. Sometimes I return to the start point, and you have to U-turn. You have to think quite a bit. And I came up with this set of questions that I thought we should answer, right? In order to answer the question, what is the optimal dose? One of the questions we need to answer, dosing, does it relate to the circulating FSH? So if you give a dose, do you see a corresponding increase? Does it then have a corresponding increase in egg numbers? And of course, subsequently, does it lead to live birth? Because if it doesn't, then what's the point, right? So the first question around FSH concentration, indeed, this is a multi-dose FSH study, and you can see that there is indeed a corresponding dose in the plasma, and of course also inhibin B production. And then in a multi-dose study such as this, you will see that the FSH reaches a steady dose after multi-dose application after 6 to 7 days after the first dose. So simple, easy, first box ticked. Of course, there's a correlation. Now, the next question is a little bit more challenging. Eggs, egg numbers. Does a higher FSH dose means more eggs? The more I look, the more confused the picture is. The more is better, some says. No, less is more. Oh, no, well, normal 8 to 15 is actually the best. But we need eggs, but not all the eggs, and therefore quite confusing. And then when you look at the studies about whether it does or not increasing the dose of FSH, you can see that there is also some studies saying yes, of course, and others, many others, saying, not really. So a little bit confusing. And then there is this observational study, which of course is observational. There is an association observed. This is SART data looking at high dosage of FSH. And actually, when the authors look at this, they found that there is an associated, higher dose is associated with lower oocyte numbers. Now, this is similar in terms of if they divided the groups into good prognosis or poor prognosis, age, BMI, and so on. But of course, we need to be cautious when we look at data like that, because of course, it's observational data, and we still need to disentangle the causal and causal relationship. So let's look at RCTs, gold standard. So in terms of the number of eggs in low responder, high versus lower dose, And you can see here the dosage of the studies that are combined, 300 versus 150, 400 versus 300, 600, and so on. And in terms of oocyte number, there is unlikely going to be more X achieved beyond the 300 IU, and that's what the studies are showing. In terms of the normal responder, low versus high dose, this is a meta-analysis here. You can see 10 studies in normal responder, and the authors looked at 100 versus 200, 150 versus 200 or greater. And you can see in terms of egg numbers, there are lower eggs with the lower dose. Okay, so this seems simple so far. And then in terms of the high responder, the high versus the low dose, again, the RCT here showing 150 versus 100, and multi-dose study, which was mentioned earlier, there seemed to be an increased number of eggs with increased dose, a trend, pattern. So, what is the conclusion with regard to egg numbers? Well, yes, there is a correlation in terms of egg numbers with FSH dose, but it doesn't just keep going up. There is a limit. There's a limit. So that brings us to the very last question around live birth, right? What about pregnancy rates? Because that's what we care about, pregnancy rates. So what does the RCT say in low responder? So high versus lower dose, and here you can see that there's no evidence to suggest increased dosing beyond 150 in low responders is beneficial. Okay, so no difference in live birth, no difference in live birth. Okay, so what's ASH's recommendation? Well, they take a more conservative conclusion over the lower dose, so it's unclear whether higher gonadotrophin dose is recommended over 150, but there is a strong recommendation that higher than 300 is not recommended. In my opinion, therefore, at the moment, optimal dose is likely to fall between 150 to 300. Now, pregnancy rates for normal responder, low versus higher dose. You've seen this meta-analysis earlier on egg numbers, but what about the pregnancy rates? Well, they actually found no difference. You can see here there's no difference in clinical pregnancy rates. And in fact, also no difference in the number of frozen embryos suitable for freezing. Okay? So therefore, ASH's recommendation, and this is guideline, as you can see here, reduce gonadotrophin dose is probably not recommended over a conventional dose for predicted normal responder. Optimal dose likely 150 to 300. Now, what about high responder? High versus low dose. No difference in the live birth rate, but interestingly, a possible reduction in OHSS rate. Okay, so again, sound recommendations from NICE, from ASHA, again, talking about antagonist protocol, recommended for high responder, but here we're looking at, reduce gonadotrophin dose recommended to decrease OHSS rate. So for high responder, optimal dose probably falls somewhere between 100 and 150. So live birth, the answer, in my opinion, optimal dose falls between 150 300. Now, the previous speaker has already touched upon the question around whether we should be individualizing or one size fits all. And here, individualization, I have to stress, is using ovarian reserve testing. We're not talking about other aspects which was raised earlier. This is purely looking at studies that had used ovarian reserve testing to assess response. And we already also have heard that we can very well class patients into different responders, poor, normal, and high. And various studies use different definitions that suits their center. And that's one thing we need to remember when you interpret studies. Different centers use different parameters to assess response. And so what did the studies find? Well, actually, using ovarian reserve testing algorithms to dose didn't actually improve the live birth rate, right? And in fact, previous speaker already raised that there were new studies that were that had been completed, and I sneakily did a quick meta-analysis, and still the odds ratio showed that it's unlikely to impact on live birth at the moment. However, of course, there is a significant reduction in OHSS rate, and therefore it, it does have that safety profile, which was already mentioned in the previous talk. Moreover, the cycle cancellation rates are lower, and of course, the duration of treatment and the dosage is lower. Oop.
Houston, we have a problem. Please, could you fix the PowerPoint?
Do you remember which number? Yep.
Just there. Excellent. So, so individualizing doses, right? If we use ovarian reserve-based testing, decreases OHSS cycle cancellation and reduce those in terms of FSH. Okay. Now, the last part of my talk, I like to be talking a little bit about refining our thinking. So why is it so confusing? Why is it so hard to find this magic dose that is optimal? Why can't we just say, to our nurse, 125, or our patient, just give 150 or 310, 219? Why is it so difficult to find the magic dose? Well, because if you think in medicine, right, cancer, for example, take any cancer. There's, of course, medication to treat the cancer. There's treatment modalities that then you can, obviously start treating your cancer. But it does not always equate to survival. Well, because it depends on the type of cancer, when is it diagnosed, whether there are actually indeed treatment modalities that can improve survival. And I draw the analogy here for fertility. Infertility, FSH dosage, if you just look at that, you give your you start your ovarian stimulation on your patients, but it does not equate always to prognosis because there are too many heterogeneous variables that we have not yet taken into account. And this is biological, but also contextual. So we've got to be mindful that dosage or one thing doesn't actually equate always to prognosis, right? And of course, there are multifactorial factors here. You're talking about receptivity, you're talking about laboratory findings, embryos, egg quality, and the human factors, which we always ignore. So there is a missing step here. We're nearly there, but not quite. There is a missing piece of the puzzle that we still have to work hard to find the answer. So in conclusion, ladies and gentlemen, there is a corresponding dose, right, as I said earlier, in terms of FSH administration, but increasing the dose does not always equate to increase egg numbers, and it does not always equate to better prognosis. Optimal dose, in my opinion, in terms of what the studies are suggesting at the moment, is anywhere between 150 to 300. Below that, you get under response potentially. Above that, you're not going to get anything better. Dosing through individualization via ovarian reserve testing-based algorithm compared to standard dosing doesn't actually improve the live birth, but it does reduce OHSS and cycle cancellation rate. From a patient safety point of view, totally agree with the previous speaker. Ovarian reserve testing algorithm is therefore superior, although, of course, we need to remember the logistical and the cost consideration. Where in your setting and in your context, you do not have the ability or have any ovarian reserve testing algorithm or ability to do the ovarian testing, actually, standard dosing, 150, works. So in the future, I see, the future is bright because as of today, we've already heard a lot of new presentations around machine learning, AI. I mean, you know, we are succeeding or is trying to, you know, pull in all these other areas of medicine that work with interdisciplines to try to refine individualization. That means collating individual characteristics and response data, amalgamating real-time in vivo and in vitro monitoring data. These are coming, right? And then using analytics in data science and bioinformatics to further that. And that day we'll be able to tailor-made individualized protocols for your center. Imagine that. So, and the other 2 points I want to make is, of course, we need to better understand biological heterogeneity and individual response. We need to better understand organizational heterogeneity, patient, human factors, how they influence care and response. And totally, really important that we need industry, academic, and clinical collaboration to take this into the bright future. So with this, thank you very much, ladies and gentlemen.
Thank you so much, Ian. Now we have time for a question. Please state your name and make the question.
Ying, congratulations.
Excuse me. I would like to have silent, please. Thank you.
Hi, I'm George Lainas. Ying, congratulations to both the presenters.
Closer to the microphone, George.
I was just wondering, we're talking about oocyte numbers and we're talking about live birth, but we want to transfer one embryo, perform a single embryo transfer, and wait for the live birth rate. When we're talking about oocyte numbers, shouldn't we reflect on cumulative live birth rate? And this shouldn't be the term outcome? What is your view on that?
If I get your question right, yes, of course. I think you know what you're saying is if we're looking at oocyte number, we ought to be also looking at live birth. Yeah, absolutely, absolutely. And that's why there is a misconception sometimes that we're overexcited about eggs, and we've forgotten that actually what is the most important endpoint, and also of course the safety profile. So totally, George, I absolutely agree with that. Yeah.
Thanks.
Please.
Human Fatemi, Abu Dhabi. Thank you, Ing. As usual, great presentation. You know, when Stratis and I, we were working in Brussels, we used to measure for study purposes, for clinical purposes, FSH during all the cycle. And we continue doing so. So still today, we measure the systemic FSH for all patients who are undergoing stimulation. And over the past 6 months, we published a few papers putting a link, as you correctly mentioned, to the huge variation that you have. Now imagine you have 2 patients, copy-paste, same demographics, same ovarian reserve, same body mass index. You give them at the same time the same dose of FSH, exactly the same time. And you measure after exactly the same hours the systemic FSH. One of them would have an FSH of 7, which is physiologic. The other one will have an FSH of 27, which is obviously supraphysiologic. And I think this is a point when we speak about the individualization that we have completely neglected. So this paper was published 6 months ago. And at ESHRE this year, we have a paper demonstrating that systemic FSH levels on the day of final oocyte maturation are directly linked to aneuploidy. because Professor Filicori, who is present in the room, he published many years ago a paper describing that there is a link between FSH and LH receptor creation. So most probably we are doing harm by giving too much of FSH. But my comment to you would be, you know, we have patients, you give 450 units and they have a systemic level of 10. If you have a guideline saying you have to stay between 150 and 300, but a patient with 450 has an FSH of 9 or 10, what do you do then?
What would you do?
Call Human. Give him a call and ask him. Huh?
Yeah, I mean, this is why it's not one size fits all. You have patients with 150 FSH, they have levels of 27. That's very high, and that's too much for that patient. I think the question would be, what is the correct systemic FSH required for a correct stimulation? And then you have to distinguish, are you in the beginning of the follicular phase or towards the end of the follicular phase? Because we know once you go towards the end of the follicular phase, you have only 5 to 10% FSH receptors. So you do not require that high levels. However, in the beginning, you need high levels to have a multifollicular recruitment. I think when we speak about individualization, it is starting at a certain dose to have your multifollicular recruitment, but once the number of receptors, FSH receptors, decline, to do the step down. But the question would be, what is a good level in the beginning, and what is a good level at the end? And I think this is where the research should go to.
Well, indeed, thank you for that question. Yeah, I totally agree. Heterogeneity biologically is huge, and we don't know how to measure it properly yet. So to the day where we have biological markers and data that we can monitor in vivo in real time, I think that's the day, you know, we can really be very precise. But at the moment, there is a huge range, and that's why there is a huge different ways people do things. But totally, I agree with that. Yeah.
Good afternoon. First of all, thank you for a wonderful presentation. I'm Dr. Rashmi Nayak from India. I have a small question. Since there was a slide, one of your slides said that in response to ovarian stimulation, what are the predictors you're taking? As you said, the basal FSH is actually considered only in the poor responders. In fact, there is no role of FSH monitoring in a normal responder or a hyper responder. So in your clinical practice, what do you think is the single most predictor for us to choose the FSH threshold for a patient? Like, do you consider an AFC or an AMH as a single most predictor? Because in some of the cases, we do see that there's a lot of discrepancy between the AFC and the AMH. So according to your practice, ma'am, which one do you think is the single most predictor for us to take it into consideration before deciding this gonadotropin dosage for a patient as optimal?
A single yes or no answer. Well, I agree. We do see AFC and AMH sometimes discrepancy, and that's, you know, previous speakers already mentioned that you know, there are assays issue and so on sometimes. But also be mindful that AFC also has this issue in terms of subjectivity, you know, it's a subjective measure. So I think for me, if I were asked that in clinic, say a nurse comes up and say, oh, you know, AFC doesn't match the AMH, I would look at the set of circumstances. Your skill set, the people and the patient, what were their previous experience, what were the previous cycles, stimulation. So I don't always pick one. It depends, But I would look at the set of context, which is what I was talking about, the context which the clinical problem is put to me, rather than saying you got to do this or this and be dogmatic about it. And that's medicine.
Like in our country, we do not repeat serum AMH repeatedly.
Excuse me, we have other question.
We can talk later, don't we?
Yeah.
Thank you.
Short question, please, so we can...
It's a very short question. Thank you for your nice presentation. It's Burcu Özbakır from Northern Cyprus. My question is about the high responders, actually, who are the oocyte donors, not the infertile patients. As we don't have the pregnancy, so the multiple pregnancy risk and also cycle cancellation risk with the poor response is not a case in this situation, what would be the optimum dose?
Interesting. So with the high responder, if they're PCOS, for example, in our center, we do not select those as egg donors, number one, because sometimes it's quite unpredictable, their response. But if they are not PCOS and you're still with a high AMH, then normally anything between 150, maybe a little bit above that, but no more than that. Purely because they're egg donors, as you say. So the last thing you want for them is hyperstimulation.
Yeah, exactly.
Yeah?
Okay, thank you.
Yeah.
Okay.
Thank you very much. Very interesting lecture. I have a question about, you talk about a lot about the dose of gonadotrophins, but not about the type. Do you prefer to add LH in some group, and maybe it will be beneficial for some patient? I want to, or maybe you prefer recombinant or urinary or combination. Does it help to get more oocyte? I want to know your opinion. Thank you.
Yeah,
I told you
I
that
was
was
so glad my title was the gonadotrophins and not. So I stuck to FSH and not LH. So as far as I know, in terms of evidence, the LH addition doesn't change the life prognosis. That's RCT. Yeah. Does that answer your question?
We have a question. Is fine? Is that fine?
Yes,
Okay.
and about urinary or maybe only recombinant you choose, or sometimes you...
Yeah, she told you
again, I mean,
no differences.
No difference.
She told you no difference. It's not my opinion anyway, because I'm the chair here, but she answered it that way. We have a question from the auditorium on the web. What is the dose recommended in obese, low responders, BMI 35? I told you that it was a tough topic. Just decrease. I think the real dose is to decrease the weight.
Absolutely. So for those of you who've been to the pre-congress yesterday, you know my ABC strategy. And if you're not there, please look back in the course. So the first is assess the patient. If they're overweight, modifiable factors, ask them to reduce their weight first. So that's my answer to that question.
Ying, maybe this is the last question. Both you and Bart described a very difficult and confusing picture regarding this topic. But isn't it, besides avoiding poetic terms such as ovarian stimulation and in fact describing what we are doing, which is FSH administration for multifollicular development, besides this, shouldn't we define a little bit better our outcome measures? George Linus suggested cumulative live birth, but is it really live birth, the outcome measure that the patient wants? I think the couples come to us because they want to complete their family. And this might mean one live birth, but maybe 2 or 3. And in this case, the outcome, what you suggest as an optimal dose or an optimal number of oocytes could be different. And is it also justified in 2022 to give such importance to HSS when we know it's completely unavoidable? I think we're just distorting the picture and we will never find an answer. So what's your opinion, please?
I think you've given a very good opinion as status. I do agree that patients come to us, and obviously the most important bit is live birth. But I do want to add that actually a lot of patients do want to be looked after and be given the choice, given the option to try. And so, you know,
Thank you.
Yeah, exactly. I'm speechless.
Okay. Thank you so much. We are going to close the section. I would like to congratulate both the speakers for their lectures. Have a good lunch.